Okay. Can you hear me?
Yes.
Oh, I'm so sorry about that. I don't know what's going on with my computer. Okay. My name is Marwa, and our topic today is necrotizing fasciitis, and I will be taking us through the history, and then Salah will be discussing the presentation. The discussion, sorry. Okay, so next, please. Okay, so our patient today is AM. She's a 29-year-old female wife from Mwingi, and she presented with a 6-day history of left upper limb swelling and also a 6-day history of left upper limb pain. Next, please. Okay, so the patient was last well around 1 week ago when she developed swelling of her left upper limb. So this occurred 2 days after undergoing the removal of a contraceptive implant at a local dispensary. The swelling initially began on the medial aspect of her arm at the site of the incision and progressively increased downwards. It was associated with pain in the same limb, gradual onset, sharp pain, constant, with no exacerbating or relieving factors. The pain was severe, that's a 10 out of 10 on the pain scale score, and she was unable to use the limb. Later that day, she noticed drainage of small amounts of foul-smelling pus and mixed with blood, and she started to also experience hotness of body, which was intermittent, associated with chills and sweating. So at this point, she also noticed that her skin had started to peel off. She's not diabetic and has medical conditions, so no liver or kidney disease. She reports that her RBD status is negative and there's no history of alcohol consumption. She initially sought medical attention at a peripheral facility where she was admitted for 4 days before being referred to KNH for further management. So while at that facility, she reports that cleaning and dressing was done. Cleaning and dressing of the wound was done, and at KNH, investigations have been done, and she was started on analgesia, antibiotics, and is awaiting operative management. So for our past medical history, this is her index non-obstetric admission. She has no history of any previous surgeries. There are no known food or drug allergies, and she has no history of any previous blood transfusions. For our past OB/GYN history, she's 0. All her deliveries SE. Last menstrual period was on the 14th of April, and her menses usually last around 3 days, regular with no dysmenorrhea. There's a history of contraceptive use, which I mentioned earlier. She was on progesterone contraceptive implant from 2nd of May of 2021 to 2nd of May of this year. So for her family and social history, she's married, a mother of 2, a 7-year-old son and a 2-year-old daughter. Both of her parents are alive and well. She's the 6th one of 8 children, and all her siblings are alive and well. There's no known history of any chronic medical conditions in the family, and she reports that she does not smoke tobacco or consume alcohol. And highest level of education is Form 4, and she does not have NHIF. For the review of systems, for CNS, there's no headache, no loss of consciousness, no weakness and no altered sensation. For rest and severe shortness of breath, no cough and no palpitations. For GUT, no abdominal pain, no vomiting, and no changes in bowel habits. For GUT, no hematuria, no dysuria, and no changes in frequency of urination. So in summary, this is EM, a 29-year-old housewife from Mwingi who presented with a 6-day history of unilateral swelling and pain of her left upper limb associated with drainage of pus and blood. She also had hotness of body. There was no receptor on that limb 2 days prior to the onset of symptoms. She's diabetic, she's RBD negative, and has no other known chronic medical conditions. So for general examination, the patient was lying supine in bed. She was sick looking and appeared to be in good nutritional status. She had an IV cannula on her right forearm. For her vitals, her BP was 108/97. Her pulse was 109, so she was tachycardic, regular rhythm, and bounding pulse. She had a rest rate of 35 breaths per minute, so she was tachypnic. SpO2 of 95% on room air, and her temperature was 37.3. She had unilateral pitting edema of the left upper limb, no jaundice, no pallor, no clubbing, no peripheral or central cyanosis, no lymphadenopathy, no wasting, and no dehydration. Okay, for the systemic examination, So on examination of the affected limb, so that's the left upper limb, the limb was in neutral position with the elbow extended. There was generalized swelling and erythema. She had a wound on the medial aspect of her left arm, extending from the axilla to around 4 centimeters below the elbow, with irregular edges. The proximal part of the wound is gangrenous, and the pale necrotic, with pale necrotic tissue more distally and a central eschar. It was draining serous exudates, and the immediate surrounding skin was hyperpigmented and had blisters. On palpation, there was tenderness, it was warm to touch, no temperature gradient, and there was peripheral pitting edema, and there was no crepitation, and the radial pulse was palpable, and the examination of the right upper limb was essentially normal. For the swelling of the left upper limb had extended to the ipsilateral breast, so there was asymmetry. The left breast, there were no skin changes, the nipples were everted, no nipple discharge, and no palpable masses bilaterally. For the rest examination, there was no chest wall deformities. The chest movements are symmetrical. Trachea was midline. It was resonant and percussion over upper, middle, and lower lung zones bilaterally. Vesicular breath sounds were had over the upper, middle, and lower lung zones bilaterally, and no added sounds. For CVS, the precordium was not hyperactive. Apex beat was fifth intercostal space mid-clavicular line. No palpable heaves or thrills. S1, S2 was had over the apex, tricuspid, and pulmonary and aortic areas, and no murmurs were had. For abdomen, the abdomen was not distended. It was moving with respiration. Umbilicus was inverted. No surgical scars or therapeutic marks. No superficial vessels seen. There was no tenderness or palpation, and no obvious muscles felt. And the limb and the skin were not palpable below the costal margins. Okay, so my impression was that this was a soft tissue infection, most likely necrotizing fasciitis, because there were poorly defined margins of the erythema with gangrenous skin, the pili, and the edema extending beyond the erythema, and also the severe pain from the history. And I had a differential diagnosis of cellulitis. It could also be other things like DVT, compartment syndrome. I also thought at this point that the patient may be in sepsis because she had met two of the SARS criteria. She had a heart rate of more than 90 and a respiratory rate of more than 20, and the presence of the infection as well. Sorry. Salah, next, please. Hello? Hello?
No, the presentation. Sorry. The presentation was good. Though I will ask you a few questions later. Let's have the discussion by Salah, and then we will see. You have done very well as far as I'm concerned. We will see what after the discussion about the essentials of diagnosis that you gave us. The list of I want you to clearly differentiate why it's necrotising fasciitis and not cellulitis on history and physical examination. So let's go to the discussion. Then we'll talk about. We'll go back retrospectively. We'll go back to the history. Thank you very much.
Welcome.
Am I audible?
Yes, you are.
Bismillahirrahmanirrahim. We begin with straight to the point. Now, necrotizing fasciitis falls under the big family disease, the necrotizing soft tissue infections, which is made up of necrotizing fasciitis, necrotizing myositis, necrotizing cellulitis. Now, these infections are characterized clinically by fulminant tissue destruction, systemic signs, and toxicity. Now, we will focus more on necrotizing fasciitis for now because of time. Now, moving on forward, necrotizing fasciitis is an infection of deep soft tissues that result in progressive destruction of muscle fascia and overlying subcutaneous tissue. Now, the infection typically spreads along the muscle fascia due to its relatively poor blood supply. The muscle tissue is frequently spared because of its generous blood supply. Now we have a classification of necrotizing fasciitis. We have type 1, 2, 3, 4, and with organisms involved. Now we have polymicrobial, which is type 1. The association here, we have diabetes, immunocompromised, peripheral vascular disease, and we also have for example of polymicrobial microorganisms are the aerobics and anaerobic bacteria. The anaerobic ones, I think the most common ones are the Clostridium perfringens, bacteroids, and Streptococcus. We also have gram-negative rods like E. coli and Klebsiella. The monomicrobial microorganisms, most Staphylococcus group and Staphylococcus aureus, including the MRSA. Now, the association in monomicrobial, we have patients with a history of trauma or surgery. The other less common types are the Vibrio vulnificus for the marine exposures and the fungols, especially the Candida species for immunocompromised patients. Moving on forward to pathophysiology. Now the bacteria, we have bacterial entry. The bacteria will enter the body either through a surgical wound or cut or an insect bite. The most common causative bacteria are the group A Streptococcus and MRSA. Now the bacteria will colonize and spread, will multiply and colonize the subcutaneous tissue, spreading along the facial fence. It will release enzymes and toxins. Now these enzymes and toxins that are released will destroy the surrounding tissue and impair blood flow to the area, which will compromise the delivery of oxygen and nutrient to the tissues. The toxin release systemic inflammatory response, leading to symptoms such as fever and generalized malaise. Now we will have immune response, where the host immune responds to the bacterial invasion by activating an inflammatory response. The combination of bacterial invasion, tissue destruction, impaired blood supply, and dysregulated immune response can result in tissue necrosis. And moving on forward to clinical features, we have early stage infections and late stage infections. The early ones include localized pain or pain specific to one area of the body that's out of proportion, edema or swelling without discoloration, fever, pain and swelling or redness that is rapidly spreading. Now the late stage infections, clinical features or clinical presentations will be having indurations, hardening or toughness of the affected area, paresthesia, will be skin tingling, prickling, numbness or burning without apparent cause. We'll also have discoloration of the skin, including a dark, black or slightly bruised appearance. We'll also have wound discharge that is abnormal in color or has a foul odor. Now we'll also have blistering of the skin and fever. Now, the risk factors include obesity, alcoholism, immunosuppressed patients with HIV, patients with malignancies, cancer, cirrhosis, and diabetes. Also, pregnant in women, we have pregnancy, childbirth, miscarriages, and or gynecological procedures. Skin breach, where we have varicella lesion, insect bite, injection drug use. Major penetrating trauma, minor lacerations like muscle strain, sprain, or even contusions, and blunt traumas. Also, we have recent surgeries such as colonic surgeries, urological surgeries, as well as neonatal circumcision. Now, moving on forward to the lab diagnosis. Now, we will do the basic blood works, complete blood work. The patients, most of the time, the lab findings are generally non-specific. But here we will get leukocytosis with left shift. We'll do basic metabolic panel. We might get for hyperglycemias. Inflammatory markers, we will have increased CRP and ESR. We will also have elevated creatine kinase and also AST. Now, in cases where you see elevated CK and AST, this suggests that we have deep infection, where it involves the muscles and the fascia. Now, microbiology, we do type of bacteria is present that's going to help us in the management, the specific antibiotic. Now, for imaging, we would normally do X-rays and a CT scan to detect air in soft tissues. Most of CT scan also helps us in finding fluid collections, also inflammatory changes beneath the fascia. Less commonly, MRI is also done, and also ultrasound is also done to localize in cases of abscess. Moving on forward now, and we have there's the diagnostic criteria called the laboratory risk indicator for necrotizing fasciitis. Now this one is a scoring system where if you get less than 5, it's indicative of a low risk, less than 50%. A score of 6 to 7 will give you an intermediate risk, and a score of 8 and more indicates a high risk of more than 75%. Now the scoring is based on the following criteria. We have hemoglobin of those ranges more than 13.5, 11 to 13. Now there will be a scoring system. It also involves white cells, sodium, creatine, and glucose, and also C-reactive protein. Now, if you get the total score, and it will guide you to which category. Is it intermediate, low risk, or high risk? Now, moving on forward. Now, for the management, first action, in case of these scenarios, admit patients with suspected or confirmed necrotising fasciitis. We start immediate surgical and medical treatment. If aggressive, consult supportive care for the sepsis. Now, for the surgical exploration and debridement, this is the only way to establish the diagnosis of necrotizing infection. The findings on direct examination include swollen and dull gray appearance of the fascia, thin exudate without clear purulence, and easy separation of the tissue planes by blunt dissection. We also have antibiotic cover. We start with systemic broad-spectrum antibiotic therapy, amoxicillin, amoxiclav, cycline, azithromycin. Now, in toxic shock syndrome, if it's suspected, we administrate antitoxin active antibiotic, which is clindamycin. We don't forget about the hemodynamic status of the patients. Make sure you have your fluids are on, and also oxygen therapy. Now, the prognosis of necrotizing fasciitis is it's a serious life-threatening infection with a mortality rate of ranging from 20 to 80%. Poor prognosis may be linked to certain streptococcal strains, advanced age and controlled diabetes, state of the immunosuppression, and delayed surgery. Even people who survive have a prolonged recovery with significant functional deficits. We have some few complications like toxic shock, severe scarring, sepsis, abscess, multi-organ failure. Severe necrosis will also lead to amputation of the affected limb. The worst complication is death, high mortality rate even with an adequate treatment. Now we have differential diagnosis like cellulitis. Now cellulitis most of the time it also presents like necrotizing fasciitis, but for cellulitis it is not generally associated with hemodynamic instability or tenderness of so. Now there's also pyoderma gangrenosum. Now it also presents typically like necrotizing fasciitis, but it has a slow progression rate. It doesn't respond to antibiotics, and it responds well to immunosuppressive therapy, unlike necrotizing fasciitis. It also worsens with surgery. That is pyoderma gangrenosum. We also have epididymitis, gas gangrene, and otitis, testicular torsion, toxic shock syndrome. That is it from my side, I think. Nectari, I think it's time. You're welcome.
Thank you very much again, Salah. I think I'm talking to Salah, the last year, Salah Ahmed. very good presentation, summarized, and you have done your best. I just wanted to make you here from my point of view. The two conditions, one on the condition first on your list as a differential was cellulitis. And many people, what actually, whether in KNH, which I was there, was general where I'm running as a referral facility, people still confused. Sometimes you see a patient who was referred maybe by some other facility as cellulitis. But by the time you see the patient, when you examine that patient, you will see this is necrotizing fasciitis. You mentioned, you lectured very well, and what the differences that the two conditions have. Of course, from Marwa's presentation, Dr. Marwa's presentation, that patient, that referral from Mwingi, I think in Kitui County. If you look at Salah's discussion and the last presentation, etiology, he has put trauma and apocatkati just around among the. He gave other other states, like for instance, I've not seen something that I wanted to see also. I don't know, maybe perhaps I've not seen that one. There are very many conditions which are very common. The commonest condition for both of them, cellulitis and also a neck fash or necrotizing fasciitis, is trauma. That lady from Mwingi that was presented earlier before the discussion by Dr. Salah was, the lady had an implant which was removed. So that's trauma already, which led perhaps to cellulitis and progressed to necrotizing fasciitis. So I want to say in this gathering today that the commonest cause of both conditions is trauma. So the patient, when you're taking history of such patient, your history must be a focused history. The first thing you should ask, it should be any history of trauma. I think that should be taken. The other, the DM, HIV, and we have in cost here something very common, intravenous drug users. If those ones now is common, those are not the things you must ask. The social history of the patient very quickly. That is something that has come out very clearly in the presentation. For necrotizing fasciitis, what's the difference now between the two? Are they interchangeably used? Salah has done a very good job on the etiology and the types. He has given us the polymicrobial type, monomicrobial type, the other two types, including the one which is mainly caused by Enterobacteriaceae, the Vibrio type, and the last one that was mostly fungal. The one that we normally come across is the first two. The polymicrobial type is very common. Most patients just say, most people in the facilities don't understand what should be done. People just misuse antibiotics. So for cellulitis, basically is both of them, if I may combine their definition, is fast progressing, but it's not life-threatening. For cellulitis, you have to include in your definition non-suppurative. If you see past, then that's something else. It's either a neck fash or it is pyomecystitis or something else. But if there is a very fast-spreading, rapidly progressing inflammation of the dermal and subdermal tissue, that one definitely is cellulitis. With all the features, the risk factors on both cases are the same. But if just in the absence of pus, in the absence of what we have just described of necrotizing fasciitis, of that skin changes, sometimes crepita, somebody is very fast spreading, and it is life-threatening because it affects. He told us very well in the presentation that the muscle is somehow spared. In some cases, even you will find when you're doing surgery, some of the muscle parts is necrosed, but basically it is affect the subcutaneous tissue and the fascia, plus or minus. Skin is mainly involved, but mainly subcutaneous tissue and the fascia is what's involved, and there is inflammation and there is necrosis, inflammation, necrosis, fast spreading, life-threatening condition that affect the something. Again, I have to the rest of the. I have no issue with the rest of the lecture. Something of note, but when I saw the management in Dr. Salah's presentation, the first thing, and he noted that one very carefully, in the before the management, history and physical examination. That's the first thing you will do before you send the patient for investigation. There's something he mentioned, and I was even telling Dr. Marwa what about the history. the patient will have, she said, the patient she talked to is the pain scale was 10 over 10. And then Salah in his own word said, pain out of proportion. That's the key words you guys should adopt. The patient will tell you it was out of proportion. It was severe pain. So that's the first thing that the patient will come to you, especially in necrotizing fasciitis. Then other things are edema. Of course, you might have hemodynamic instability. He mentioned that one very critical also. Hemodynamic instability, that's the most important thing. By the time the patient comes, presumably the patient is in shock, and you have to do, before you send the patient, the way I saw among the investigations, MRI, it's a surgical emergency. By the time the patients come to casualty, is he hemodynamically stable? That's the first thing you check. Management starts with actually ATLS, the way that protocol, airway and those things. Is the patient breathing? How? Because some of them even already they're saturating by the time they're coming to casualty. They're septic. They're already in septic shock. So those are the things that should come at the back of your mind. If the patient is stable, then you can have time to do X-rays and those things. But in most cases, it's a clinical diagnosis. The patient is very severely in pain. You have to intervene, take the patient to the surgery. Not all patients with cellulitis are taken for surgery. Those ones sometimes elevation, antibiotics, and so on and so forth. But for necrotizing fasciitis, you must take that patient to theater as soon as possible. And of course, in theater, you will open, depending, mostly is the limbs. The one that he was telling us something about the groin and the scrotum, that one is, of course, also on the neck, something called Ludwig's angina. Sometimes it can affect also the genitourinary system. You must open the fascial plane, remove the dead and necrosed tissues, at least open the. You do that, his life is at risk. So those are the key points I have to make about generally cellulitis and neck fascia. I was just told this lecture about 24 hours ago. Right now, I'm actually in the hospital. I was coming out from this surgery. I had to come with my laptop because I knew I would delay and use the office in the hospital there. Otherwise, if you have questions, you can ask me. And next time, if you want me to present something, tell me, give me some time so that at least I contribute more for you. Thank you very much.
Thank you very much as well. Again, thank you for accepting to take us through this session on a very short notice. We can give them maybe 1 or 2 minutes to either type up their questions or unmute themselves and ask themselves.
Why are we quiet? I think guys will ask questions. Either we have whatever the three of us talk about is either all understood or we have just confused you more. You can ask question to Dr. Marwa, Dr. Salah, and myself, and anything about the patient, about the presentation, and about the overview I've given of all they have given earlier. So anybody can, or if you have someone who wants to contribute and add something to the discussion, you're also welcome. Thank you very much.
Hello, I have a concern about lymphadenopathy. There was massive pus near the axilla, and there is no lymphadenopathy or lymphadenitis. Is there possibility we can have the no lymphadenopathy and such thing?
Hassan, I didn't get the question properly. Was it about the case presentation?
Yeah, it was about the case presentation in the examination. Marwa said there's no lymphadenopathies, and was thinking about the septic area being around the axilla. Will there be no possibility of axillary lymph nodes, lymphadenopathies and spherical lymph nodes then involved?
Good question. Good question, Hassan. And from my own understanding, what Marwa was presenting was somebody who had an implant along the arm, most likely is no plant that was being excised. So sometimes it's not must somebody has lymph nodes, because you see it depends with the longevity of the problem. It's an acute problem, and we might not have reached to the extent of course, if you have, if the suspected necrotizing fasciitis, perhaps you expect lymph nodes. You see, most of the lymphatic channels sometimes will be blocked, or maybe there's something because of even inflammation. They can be enlarged, but it's not must that lymph nodes are enlarged. We just take what she told us from, because she's the one who have seen the patient, but it's not must. If it was not there, perhaps the lymph nodes are not even enlarged in the first place, but sometimes even they could be there, or maybe she has examined on the she has examined the other side, but it's not a must. Sometimes patients will be having severe sepsis, severe infection, but it's not lymphadenopathy. It's not a must somebody has lymphadenopathy. How long will patient use antibiotic after debridement? Good question by Abdullah Nur. The mainstay of management is surgery. If the patient has necrotising fasciitis, the mainstay of management is surgical debridement. Take the patient to theater, stabilize. If the patient is stabilize the patient, go when he's try to. The most important thing is to remove those dead and devitalized tissues. If there are some section of the fascia, those compartments that are causing even near compartment syndrome, you release. You do a sort of fasciotomy, release all the dead tissues, and then clean, rest, and then start the patient on antibiotic. Antibiotics, it depends. You might use it for a week, maybe 10 days, depending on the level of infection, because you're also using your markers of inflammation that Hassan gave us. Salah gave us. So long as now the sepsis is down, you can just continue with the dressing the patient. Antibiotic maybe 7 days, 10 days, 14 days, depending on the level of infection. If the infection is sorted and you only have a wound that's being dressed, you just continue with the dressing. And of course, you didn't ask about what next for that patient. If the wound is clean, depending on what you have done, that patient can undergo, if the wound is small, which is very rare in necrotizing fasciitis, very rare. By the time they come to hospital and they're being debribed, the skin is destroyed, the fascia is destroyed. Those patients, most of them I've seen my short practice, they benefit from grafting. By the time you're going for grafting, it must be very clean. There's no sepsis, there's no pus, and then you do grafting and the patient is sorted. But antibiotic, it is dependent on the patient. Yeah, thank you very much, Abdullah. Any other question? You can just type if you are not there. If one is not doesn't want to speak, you can just type and we go through it. Because it's an opportunity to exchange ideas, and we benefit from one another. So that will help you guys, especially. You said you are. I expect the year 6, like Dr. Salah must have been going to theater, because when I was at the University of Nairobi, guys are like disinterested in surgery. People want to do surgery just to pass the exam, and then you come back to internship, you don't know anything about surgery. You have forgotten about everything concerning surgery. But still, we had very good people. I'm very proud of some people from University of Nairobi who are currently even my residents, who have done very well their stuff. They have never slept on the job when they were students at UON. I have colleagues who are now doing residency at Coast General Hospital and doing very well. They're doing the UON fraternity very well. So, guys, it's not much that you become surgeon, but you must